Good afternoon, my name is Debbie Illies, and today I'm going to be talking to you about a postpartum complication that's very near and dear to me in both a personal and professional capacity, and that is postpartum hemorrhage. The very basic definition of postpartum hemorrhage is excessive bleeding after delivery. We expect that after childbirth there will be some bleeding, with an amount of about 250 to 500 milliliters being considered normal. Postpartum hemorrhage comes into play when that amount starts to exceed 1,000 milliliters and the patient is showing clinical signs or symptoms. Postpartum hemorrhage can be broken down into two categories, primary and secondary. Primary is the most common, and it's when the hemorrhage occurs within the first 24 hours of delivery. Secondary is when the hemorrhage occurs anywhere from 24 hours up until 12 weeks after delivery. So there is a very long length of time that postpartum patients are at risk of this occurring. Postpartum hemorrhage is interesting in the fact that it can have many different causes, and the treatment and management is catered depending on what the causes or combination of causes are. The causes are often narrowed down into what we call the 4 T's, and that stands for trauma, tissue, thrombin, and tone. Trauma meaning if there was anything traumatic during the labor, such as a laceration that occurred, or if there was either a very quick or very slow or prolonged labor, if there were any assistive devices used or a C-section, all of those could be considered traumatic. Tissue refers to anything that was retained after delivery, so if a woman retained part of the placenta in her uterus or other tissue, or if she developed and retained a blood clot. Thrombin would describe a cause if clotting disorders are at play and the blood cells are not clotting and controlling bleeding how we would hope they would. And finally, tone refers to uterine atony, and that would mean that the uterus is kind of boggy, it's not quite clamping down and decreasing to its normal size to control bleeding how we would expect it to. Postpartum hemorrhage is quite common. In fact, it is the leading cause of maternal mortality across the globe. It's thought to impact about 14 million women worldwide every year, and 70,000 will lose their life because of it. Even if someone does survive postpartum hemorrhage, they are still at risk of long-term complications depending on the procedures needed to control the bleeding. Typical symptoms that we see with postpartum hemorrhage is bleeding, and that can be either a big gush of bleeding, or it can be passing larger blood clots, or sustained bleeding over time that's not decreasing the further that we get out from delivery. And also if we see someone who, typically we would expect bleeding to taper off and change in color. If we're seeing someone go the opposite, that their bleeding was lighter and now it's increasing in amount, that would be a sign of concern as well. These women tend to be hypovolemic when we see them. We tend to see very high heart rates, high respiratory rates, and low blood pressure. They can often be very dizzy or lightheaded, feel run down or fatigued, and tend to be pale. Risk factors for postpartum hemorrhage include advanced maternal age, if there's any sign of maternal health issues during pregnancy, such as preeclampsia or HELP syndrome, if there's any structural disorders of the uterus, such as uterine fibroids, if a woman has any known clotting disorders, and again, any kind of trauma that would be, could put them at higher risk as well. So I would like to share a case study with you, and this is where the personal component comes in because it is about myself. When I was 26, I became pregnant with my first daughter, and I was very healthy going into it, no known health issues, a rather uneventful pregnancy and delivery, but my story starts from there. So shortly after having her, I felt very dizzy in the hospital. Whenever I would have fundal checks, they would always say it was difficult to feel. Not that it was boggy, just that it felt different from they were used to finding in their assessments. When I went home, I did feel also run down, but really had no baseline to compare to because it was my first child, so I didn't quite know what to expect. And then 5 days after delivery, I did hemorrhage at home. I actually passed a large softball-sized clot at home and then went into the hospital. By the time I got to the ER, my hemoglobin was at 8. I was very pale, very weak. They ended up doing an ultrasound, which showed that I did retain something. It ended up being a large blood clot, but because of that, they wanted to admit me and perform a D&C to remove that tissue. By the time I was admitted, they had repeated labs. Before going into the procedure, my hemoglobin had dropped to 7.4. And then during the procedure, when they were removing the blood clot, I actually had profound uterine atony where my uterus would not clamp down, and I did have excessive bleeding that required uterine tamponade, or inflating and deflating a Bakri balloon to help get that uterus to firm up and stop the bleeding. Luckily, after a couple of attempts it did, otherwise I was getting very close to needing an emergent hysterectomy. From a personal experience, this was very scary. It was our first child. It was terrifying for me and for my husband. And then going home, you're caring for a newborn when you're feeling completely run down yourself. I ended up getting 2 units of blood before I went home. Luckily for me, it was a good story. I was someone who survived it, but it was quite traumatic for our family, and it's one of the reasons I chose to talk about it today. It is very common, and there are many differential diagnoses that postpartum hemorrhage can be mistaken for, or where it may not be taken seriously. For example, if a postpartum patient is complaining of bleeding, it might be mistaken for just regular bleeding. Same with fatigue or dizziness. It could be chalked up to being tired from being up with a baby, or from, just the new stressors and change. When we think that postpartum hemorrhage can occur anywhere up through 12 weeks after delivery, that far out, we could also confuse it as the return of the menstrual cycle. There's many things it can be mistaken for, but it's really important that it be taken seriously if there's any risk that it is a hemorrhage. And that's one of the measures that the World Health Organization roadmap is looking to address. They want to find any barriers patients have encountered in getting care for this, and they want to make sure there's very clear instructions. They recommend that healthcare facilities have postpartum hemorrhage kits readily available in OB departments and in emergency rooms, so the necessary materials are ready quickly to help promote outcomes. And they want to make sure women have very direct instructions on where they should present and what they should do if these signs and symptoms occur. They've also talked about making policies at organizations so interventions can be done quickly, and having practitioners in the early days when children are seen for their weight checks, checking in with the mother too to see how she's feeling, and if she's reporting heavy bleeding or excessive fatigue or dizziness, either updating their provider or kind of taking those additional steps to investigate and make sure that she is safe and not at a higher risk of postpartum hemorrhage. As I said before, the treatment of postpartum hemorrhage is dependent on the cause. So when it's occurring, the top 3 things that we want to do for a patient is to determine the source of the bleeding, stop the bleeding, and keep the patient hemodynamically stable. So when a patient's initially presenting, if they're bleeding, a lot of times they might start with fundal massage, massaging the uterus to help it firm up and control that bleeding. A lot of times they'll be getting lab work done to check their hemoglobin or CBC. They might look at iron levels, and they're likely going to look at clotting factors to see if any of those are the cause. A bedside ultrasound may be done to look at if there's anything retained, such as a tissue or blood clot. And they might do a genital exam or pelvic exam to look internally and see if they can identify any traumatic source of bleeding, such as a laceration. The treatments that we can use for postpartum hemorrhage, like I said, would depend on what we determine the cause is. If it's due to tone and the uterus not firming up, like I said, fundal massage. Otherwise, common medications that are used are oxytocin, methergin, and cytotec. If it's determined to be due to a clotting issues, the patient may receive blood products to help control that. If it's because of retained tissue, the patient may require a DNC or surgical removal of that. So it's really depending what they determine is the actual cause of it. So immediately, those are our concerns. A lot of times the patients will be getting a large bore IV and getting fluids as well to help with some of that replacement. And they're going to be monitored closely for their fluid status, and we want to watch them for risk of falls and dizziness. As we get further out from the hemorrhage, we want to ensure that the team is managing this patient across the board, that they're really looking at all these different components. And that includes physically, so making sure they're getting rest, fluids, that they're being safe with position changes, and monitoring closely with bleeding. They're likely going to get follow-up lab work to ensure that numbers are normalizing. And we want to think of the emotional aspect. This patient might need a behavioral health referral for counseling or support, either them or their spouse, because it can be quite traumatic. The patient could also possibly benefit from a lactation consult or other referrals depending on what their needs are. Thank you for your time.